So this is a timely topic because, as many of you may know, this represents the 20th year for umbilical cord blood transplantation and the 15th year for umbilical cord blood banking. And so what I'd like to do this afternoon is review with you the current state of knowledge with regards to what we now understand, at least what we believe we understand on umbilical cord blood transplants, both worldwide and at the University of Minnesota. So as all of you know, many of our patients come to us with a malignant disorder. And for many of those patients, we hope to obtain a remission with chemotherapy, and some of them will go on to transplantation if they have an HLA matched sibling donor. Unfortunately, not all of those patients have a matched sibling donor, and some of those patients won't achieve a remission. But for those that do, they will oftentimes go on to chemotherapy. And then obviously those patients who are considered to be of sufficient high risk, or those who go on to relapse and subsequently achieve remission, will go on to receive an unrelated donor or alternative donor transplant, either with adult volunteer donor hematopoietic stem cells or umbilical cord blood. What we're trying to do in that circumstance is to take advantage of the graft versus leukemia effect or graft versus tumor effect of allogeneic stem cells. However, there are a number of factors that play a role in deciding whether or not such transplant will take place. That will include the age of the recipient, the presence of comorbidities, or the fact of whether or not a suitable donor can be identified. The problem is as shown here. Many of the patients that we see that are evaluated for the possibility of a transplant procedure because they have a disease amenable to such therapy, many of those patients are disqualified because they're considered to be too old for allogeneic hematopoietic stem cell transplant. But really more importantly, on the other side of the panel here, you can see here, as shown in blue, 15,000 patients are estimated to be eligible for hematopoietic stem cell therapies. They're in the right age group. However, no donor can be identified currently. So we're trying to figure out ways of trying to expand the uses of hematopoietic stem cell transplants and allowing such a therapy to be employed if it's considered to be optimal for the patients that are being considered. The chance of finding a donor varies by ethnic background. Those patients that are of Caucasian descent have the highest probability of finding an HLA matched or suitable donor, as you can see here, approximately 60%. And for those that are in ethnic minorities, such as Hispanics or African Americans, you see a correspondingly decreasing chance of finding a donor if we're looking for an HLA A, B, C, and DRB1 allele matched donor recipient pair. The problem then occurs that for those patients that go on to transplant, obviously we're trying to elicit the benefit of the graft versus leukemia effect, but it comes at a great cost. There's certainly a high risk of early and late toxicities, and though you know many of these, what we're focusing on now is trying to figure out ways of reducing the risks of acute and chronic graft versus host disease and opportunistic infection, although many other toxicities and morbidities are shown here. For those patients that go on to transplant with an unrelated donor using adult volunteer donors, you can see here whether we're using peripheral blood or bone marrow, the chance of dying in the first 3 years after transplantation is approximately 45%. We have to figure out ways of reducing that transplant-related mortality. We know that one factor that plays an important role is the degree of HLA mismatch. For every increment in the HLA mismatches you can see here, we find a correspondingly 9 to 10% decrease in overall survival rates. So clearly we have to figure out ways of overcoming this major obstacle of HLA matching with adult volunteer registries. Well, although there are other approaches, one possible approach is using umbilical cord blood. And the reason for considering umbilical cord blood is because one thing is that umbilical cord blood is immediately available. All the HLA types have previously been obtained, and the units are banked for immediate use. But also because of the fact that umbilical cord blood has some unique properties associated with it. It has a decreased cytotoxic potential in response to alloantigen, although it proliferates normally as compared to its peripheral blood counterpart. But there's also an increased proportion of regulatory T cells and circulating trophoplasts that may also modulate the immune system, allowing us to cross HLA barriers. But if you go back 15 to 20 years ago, when we first considered the possibility of umbilical cord blood transplants, the burden of proof was upon us to figure out whether or not, compared to bone marrow, whether or not it would retain the graft versus leukemia effect, because remember, it had a decreased alloreactive response, at least in vitro. It also must hopefully reduce the risk of transplant-related mortality and must also make access to hematopoietic stem cell therapies universal. So clearly there was a lot to be performed over the next couple of years, be able to demonstrate its place in transplant medicine. Well, from the very outset, we knew at least one thing, that there was to be associated with a very short delay in the time for the donor cell acquisition. But what have we learned subsequently about umbilical cord blood? Well, the first question is that how does survival compare to recipients of bone marrow within broad disease categories? In a recent analysis of the CIBMTR, which is updated and not published as of yet, you can see here that at least within the pediatric age group, this is patients under the age of 18 with leukemia, myelodysplastic syndrome, or myeloproliferative disorders, you can see here that compared to bone marrow, there is virtually no difference in overall outcome. You find a similar type of curve, but with higher perhaps overall probability of success in patients with immunodeficiency states, and a similar type of outcome in patients with metabolic disorders. So clearly, when you look at the overall results of cord blood, the one thing that we can conclude so far, at least with the data that has been collected thus far, that survival after umbilical cord blood transplant is at least appearing to be comparable to that observed with marrow, at least within the pediatric age group. So the second question is that remember that first analysis that I just shown you was unadjusted for many factors that can play a role in overall outcome. It was not adjusted for degree of HLA matching or ages of the recipients or different types of individual diseases. But the next question we wanted to address was really what is the impact of umbilical cord blood if we compare it to the gold standard, which is HLA allele matched bone marrow. So as some of you have seen in a report that came out approximately 9 to 10 months ago in The Lancet, what we did is we compared the results of unrelated marrow to cord blood between 1995 and 2003. There were approximately 500 recipients of bone marrow and 500 recipients of cord blood. All were children with acute leukemia as their underlying diagnosis. They all had a follow-up of approximately 4 years in the two groups of patients. As you know, bone marrow transplant requires a higher level of typing with matching at allele level at A, B, C, and DR. And umbilical cord blood has a different level of typing with antigen level requirement typing for A and B and DR at allele level, with C not being considered. So with that in mind, when you look at all the results that we'll be discussing throughout the rest of this presentation, this is the level of typing that we're talking about for cord blood. Now, in the first case, in the first slide here, what I'm showing you is the results comparing bone marrow and cord blood and looking at the outcome in terms of graft versus host disease. Obviously, from the very beginning, we were hypothesizing that umbilical cord blood would have a lower immunoreactivity and therefore hopefully translate to lower risk of acute graft versus host disease. When you look at grade 2 to 4 disease, you can see compared to the gold standard here that is matched bone marrow, that is allele level typing, you can see that those recipients with cord blood that's matched have a very low risk of acute graft versus host disease, and with any degree of mismatch, you find a little bit higher level of graft versus host disease, but clearly it compares quite favorably to matched and mismatched bone marrow. So I think the one thing we can say unequivocally is that the risk of acute graft versus host disease appears to be substantially less than that observed with bone marrow transplants, even when matched at allele level. Similarly, when we look at chronic graft versus host disease, you see that the cord blood group has an overall probability of chronic GVHD approximately half that of what you observe with bone marrow transplants. These groups of patients were lumped together because there was no difference between matched versus mismatched cord blood, but the overall risk of graft versus host disease was quite low. This resulted in overall survival outcome as shown here. The most important aspect is in the three curves that are shown at this level here. Compared to the recipients of matched bone marrow, you find that one antigen mismatched cord blood recipients and two antigen mismatched cord blood recipients have an overall outcome that's quite comparable. One group of patients, however, fell out as being significantly better, that is, those receiving matched cord blood, but this represents only a small proportion of the patients undergoing transplantation. Suffice it to say that the most important outcome is shown here, which suggests to us that no longer should cord blood be considered a second-line therapy, but in fact in the pediatric age group, at least within the confines of acute leukemia, having a one or two antigen mismatched cord blood provides you with an overall outcome that is quite similar to with the gold standard. The next question to be addressed is, what are the graft factors that predict outcome in the recipients of umbilical cord blood? But I think that most of you in this audience know what the answer is, and that is that the most important factors predicting outcome is HLA match of the cord blood unit, cell dose, and age of the recipient. Very early on, in a report that came out in 1998 by Pablo Rubenstein at the New York Blood Center, evaluating the first 562 recipients of umbilical cord blood, these two factors, or the first two factors, fell out as being quite significant and have remained important throughout time. What you see here is in terms of neutrophil recovery or risk of mortality, cell dose has an important impact upon the overall outcome. With every increment in cell dose, you see an improving rate of hematopoietic recovery as the curve shifts to the left. And in terms of mortality, with every increment in cell dose, you see that there's a correspondingly decreased risk of transplant-related mortality. Similarly, HLA match has an impact upon neutrophil recovery, but predominantly between 0 versus 1 or any type of mismatch. In terms of overall risk of mortality, every degree of mismatch gives you a correspondingly increased risk of transplant-related mortality. Therefore, it is not surprising when we look at the adult response to umbilical cord blood transplant to have a significantly lower risk of overall survival in recipients of cord blood. And you might ask, why is that the case? Well, first off, I think it's quite clear why cell dose is lower in recipients of adult recipients, and that is because the larger the size of the recipient, then there's a correspondingly lower dose because the cord blood unit is fixed in its overall number of cells. However, one thing that may not be immediately obvious is that recipients in the adult age range are more likely to receive a unit that is 2 antigen mismatched. And the reason for that is that because of the cell dose issue, as you require more cells for engrafting these patients in the adult size age range, what you find is that then the number of units that are available to those patients are much more restricted and therefore more likely to necessitate a 2 antigen mismatch graft. And indeed, this has turned out to be the case. So for adult recipients, they have actually all three factors going against them: age, lower cell dose, and a higher degree of HLA mismatch. So the next question was, what is the threshold for HLA match and cell dose? Remember, up until recently, we didn't know those answers. We made some hypotheses in the very beginning that we would require at least a 3 antigen mismatch. And some of you in this audience who have been around for the past decade or two may actually remember that we actually came up with a cell dose based on the number of long-term culture initiating cells. And in fact, we postulated that the lower limit of cell dose was a dose of 1 × 10⁷ nucleated cells per kilogram. And although that was based on some information that we thought might be useful in making that determination, it turned out to be an underestimate. And in fact, the cell dose threshold is higher than that, but we didn't know that until more recently. In terms of HLA matching, some interesting data came out recently from the COBALT experience, which was the national trial in the pediatric population, exploring how much of a mismatch we could tolerate. And let me just take you over to the right-hand panel where you can see that now looking at the high-resolution typing of the umbilical cord blood and marrow and cord blood recipients, you find that there is a population of patients shown here in red that have a very highly matched cord blood unit. But more importantly, look at the figure that's shown in blue here. These patients are receiving units between 2 to 5 matches out of 10. Although the number is still small, what is suggested here is that we don't yet know what the lower limit of HLA matching that's required. Nonetheless, from a practical point of view, we can find, for the majority of our patients, a 4 out of 6, 5 out of 6, and sometimes a 6 out of 6 umbilical cord blood graft. And so therefore, we're not frequently forced to go to lower levels of matching. But suffice it to say, we don't know what that threshold limit is for HLA matching in the setting of umbilical cord blood transplant. What we also know, though, is that the lower limit of cell dose is not a dose of 1 as previously predicted, but a lower limit is a dose of 2.5 × 10⁷ nucleated cells per kilogram as shown here. And I'll show you more data that further supports that conclusion. But now this forces us now to have a problem in trying to select donors for our patients, because now we have to weigh cell dose and degree of HLA matching and not just one over the other. Now, the question then is that compared to cell dose, does HLA match carry more weight in unit selection? Now, I'm going to tell you from the very beginning what our biases are at the University of Minnesota, and that HLA match does have higher weight over cell dose. But let me also tell you that this is not accepted around the world. Let me tell you why we believe what we believe in terms of the preference for HLA matching. One is shown here. This is based now on the Lancet report from about 10 months ago. You can see now with every increment in HLA mismatch, you find that you have an increasing incidence of transplant-related mortality. All these children had a very high cell dose, most of them having a cell dose greater than 3. But nonetheless, even in those higher cell doses, you find that with every mismatch, there is a corresponding increased risk of transplant-related mortality. But this perhaps is a better way of looking at the data. This is now looking at all patients that were undergone transplant from units from the New York Blood Center. And let me point out something to you. Look at the figures here in the pattern of survival in those receiving a 5 out of 6 graft versus a 4 out of 6 graft. What you see here is at this lower threshold now, those patients receiving a dose less than 2.5 had an exceptionally poor outcome. Again, this tells us why that lower threshold is 2.5 and above. But what you also see here is that only for those patients that have a cell dose greater than 10 is a cord blood unit that's 4 out of 6 having an outcome that is quite different than those receiving a 5 out of 6 graft. In other words, if the HLA match takes priority for units containing cell doses between 2.5 and 10, anywhere in here, you should then take a preference for the more closely matched unit. So in summary, when you're balancing cell dose and HLA match, what I would say to you is that the cell dose of 2.5 is your threshold, below which you should not do the transplant. However, when you are looking at the effect of HLA mismatch, you should adjust the threshold based on the degree of HLA mismatch. What I mean by that is that for every increment in cell dose, it decreases the negative impact of HLA mismatch, such that for those patients with a 6 out of 6, you would hopefully go after a unit that's greater than 3. For 5 out of 6, a dose of 4, and 4 to 6, a dose of 5. At least, although the absolute numbers are not quite figured out, at least the trend is try to make up for the negative effect of HLA mismatching by increasing your cell dose. Now, Elian Gluckman and Vanderson and Rocha in Paris have made these recommendations, which differs a little bit from what I've just told you. What they would suggest to you is that you first look at the number of cells, not the HLA match. So this is a different approach. Now, what I would say to you is that there is an impact upon how you would evaluate your donor searches. So what Elian and Vanderson would do is they would then list all those units that are 4 out of 6, 5 out of 6, and 6 out of 6 match with a patient, and then simply list them by the numbers of cells that were available. That would lead them to take that unit that has the highest cell dose within that degree of matching. That means that for the majority of their patients, they would most likely select a 4 out of 6 unit because you have many more choices within that HLA matching category. In contrast, what we would do here at the University of Minnesota is simply list all units that have a cell dose greater than 2.5 and simply list them in the order of HLA matching. This would lead us then to more likely choose a more closely matched unit, even if the cell dose is lower. So from a practical point of view, we would choose a cell dose, we would choose a unit that was HLA 5 out of 6 with a dose of 2.6 versus an HLA 4 out of 6 matched unit with a dose of 4.1, which is not what is universally accepted, but that's a difference in the practice. And so when evaluating the outcomes at our center, you have to keep in mind how we choose a graft in comparison to what others might be doing. So question 6, but what if there is no HLA matched single unit with a cell dose of greater than 2.5? Well, there's a couple of potential strategies that we and others are investigating. Might we improve homing, such as with CD26 inhibition, intra-bone marrow injection, or more recently investigating the possibility of incubation with C3A as a way of improving the homing of hematopoietic stem cells and progenitors, finding their way to the marrow microenvironment. There's other strategies such as using PTH or mesenchymal stem cells or ex vivo expansion protocols, or using a carrier population such as with adult haploidentical peripheral blood stem cells in combination with umbilical cord blood. Well, we've taken a different approach, and that is to consider the possibility of a double umbilical cord blood transplant. The idea is that hematopoietic stem cells from each of the two units would both contribute to hematopoiesis, and that in turn what we would hope that we would have a more rapid rate of recovery and better ultimate engraftment. So if you think of these yellow cells as being the stem cells and progenitor cells in each cord blood unit, and as you know, CD34 and cell dose predicts the time to recovery, it's a simple addition of two populations of hematopoietic stem cells from Unit 1 and Unit 2. But there is a risk. One risk that you could have bidirectional immune rejection from the lymphocytes present in Unit 1 counteracting the stem cells in Unit 2 and vice versa, and this could then lead to graft failure. Well, a pilot study was performed here back around the end of 1999 and early 2000, and in this pilot study we were able to demonstrate the safety of the approach, that of the first 23 patients, we demonstrated not only that all patients engrafted, but the median time to recovery was 23 days for this cohort of 23 patients in the adult age range. And compared to a historical control of 37 patients receiving a single umbilical cord blood unit, the overall incidence of engraftment appeared to be improved, and the median time to recovery also seemed to be shifted to the left, suggesting that if not better, at least was safe for us to proceed further. As some of you may know, the reason for then looking and exploring the possibility of using the double cord blood transplant was as a means for then exploring ex vivo expansion. But as it turned out, the actual pilot was so interesting that we actually focus now on exploring double cord blood transplant rather than ex vivo expansion, which we'll discuss in a few moments. So recall for a second that a single umbilical cord blood unit is inadequate if it achieves one of the following. That is, it must have a high cell dose, and the cell dose requirement changes with the degree of HLA mismatching, such that those receiving a 5 out of 6 graft require at least a cell dose of 4, and those with a 4 out of 6 graft a cell dose of at least 5. This is a practical approach for how you might choose a unit. The reason why I'm showing you this is that you have to know what is acceptable for a single cord blood unit before you then try to entertain the possibility of how you select a double. So if you don't have a single cord blood unit that's considered to be acceptable, the way we select a double cord blood unit, that is 2 units that are going to be infused in the patient, is first choose the best single unit that's available. The unit must have at least a cell dose of greater than 1.5, as you can see here. Obviously, the more it has, the better it would be, and the more likely we would choose that unit. This would be your first choice, because remember, these are considered to be acceptable single units and therefore are excluded from this present part of the presentation. Obviously, what we would then do is then we would go down this list depending upon what's available to us. The second unit is the second best available, but what makes this particularly difficult is it requires partial matching between Unit 1 and Unit 2. Unit 1 must be no more than 2 mismatches with the patient, and Unit 1 and Unit 2 must be no more than 2 mismatches with each other. But there are other factors that play a role in choosing the units, and one of those that I should point out to you is the lack of attached segments for quality control. Thus far, we're aware of two donors that have been sent to us, 2 units that have been sent to us thus far to date, where it turned out to be the wrong unit. It is critical that for us to do our quality control testing, we can't rely simply on the fact that there is a unit that has been previously typed and has an associated segment but is not linked with the unit itself. In those cases, we have a unique problem in that there is the possibility that the unit and the segments may not be actually belonging to each other. And yet we then evaluate that segment that is separated from the unit, and it may be not representative of the unit we think that it is. So practically what happens is that for those units that do not have an attached segment, we actually require rapid HLA typing at the time of the unit thaw. Within 3 hours, we receive the results, and we have the unique ability to do that here, but not all transplant centers have that ability as they move forward, risking the chance that they might be infusing in the wrong unit. Practically speaking, this doesn't happen very frequently, but it's a preventable cause of death, for which we believe that all units that do not have an attached segment should have rapid HLA typing at the time of thaw. Now, moving on, when we actually began the double cord blood approach, what we didn't know was how frequently we'd be able to find donors. What I can tell you is that we have a 93% chance of finding a suitable donor taking this approach, and the reason for that high number is that, number one, we can find adequately matched units for our patients, but the double cord blood platform now allows us to achieve an adequate cell dose. Only 30% of the time, roughly, are you able to find an adequate single unit with the cell doses and matching that's required. However, the double cord blood platform not only allows us to have the right HLA matching, but also now allows us to achieve an adequate cell dose, such that 70% of our patients will now undergo a double umbilical cord blood transplant. In some circumstances, we select bone marrow as our first priority, but this represents only a minority of the transplants performed at this institution at this point in time. When you look at now the overall results for patients receiving a myeloablative umbilical cord blood transplant here, you can see here that there is no difference in the overall outcome between singles versus doubles, but remember you only receive a large single cord blood transplant because it has a cell dose greater than 3, and everyone else receives the double. So now the majority of patients are in this category shown in yellow, but what you can see here that the median time to recovery is 21 days with an overall cumulative incidence of 93%. And you can see when you did the multivariate analysis, the only factor that predicts the outcome is the cumulative number of hematopoietic stem cells as marked by CD34, and predicting the outcome, whether it's single or double, it's the total number that predicts rate of recovery and overall probability of engraftment. So now this gives us now a new strategy for trying to attack the major problem in adults, which is this very delayed recovery and poor engraftment status that would be observed with a single umbilical cord blood transplant, at least as previously reported to the the International Bone Marrow Transplant Registry. You can see here that the overall incidence of recovery is about 26, 27 days, with an overall probability of engraftment of 79%. And you can see compared to our data is 21 days versus 93%, giving us reasons to believe that this double cord blood platform could be a marked advantage in patients being considered for cord blood transplant in general. So what do we know about double cord blood transplant and engraftment? We know that engraftment in adults is comparable to or better than that reported in children in the COBALT study, which was 80.7%. Nearly all adults are now eligible for cord blood transplant, and the combined cell doses of units 1 and 2 are the most significant predictors of engraftment outcome. So what is the contribution of that second unit? Well, what we can tell you is the incidence of dual chimerism, that is chimerism derived from unit 1 and unit 2, varies with the time point for which you do the analysis. At the earliest time points, at day 14, you can see that more than half of the patients will have evidence of both donors. But with time, one donor will win out. There's been only 5 cases out of the first 320 patients that were actually able to see a persistent dual chimerism for a prolonged period of time. So for all intents and purposes, that second unit only contributes to early recovery in our patients. To show you pictorially what it would look like is that what you see in many of our patients is that one unit will have a transient recovery that will disappear over time. There's virtually no host seen in patients receiving a myeloablative prep, and you can see that one unit will win out. But which unit wins? Is it A or B? Now, unit A or B isn't necessarily the first unit that's infused, and in fact, infusion order and all the rest of these parameters have no impact upon determining which unit will ultimately win out. So the question is engraftment random between the two units? Well, what is the mechanism of the improved engraftment with double cord blood transplant? What I would suggest to you, although I don't have the data to prove this to you yet, is that fludarabine and perhaps cells within unit 2 suppress host resistance and enhance chimerism, and that unit 2 adds hematopoietic stem cell progenitors, which in turn speeds the rate of recovery. We're doing a number of analyses now to see if we can prove the mechanisms here, but this is what we're thinking may be happening, although have yet to prove. In terms of the overall outcomes, in terms of those patients receiving a double cord blood transplant, you can see that the probability of transplant-related mortality in adults receiving a full preparative therapy is 22%. And the overall survival rate is 63% in this first group of patients. So when we look at then the survival of just patients receiving double cord blood transplants for AML and ALL in first and second remission, what's interesting is that we find an overall survival rate that is 72%, which is better than what we've seen with children. And as far as we know, this is unprecedented to see results in adults better than in children. We went back to look at why might this be the case, and in fact, if you then just look at those patients that have survived beyond 9 months, the reason for looking at that, we wanted to tease out what the late events were, and why was there a difference between these two groups of patients. What we know is that 87% of the late events in children were due to relapse, which has not been observed and those receiving double cord blood transplants. Well, this then led us to a seventh question was, why or is there a lower risk of relapse in recipients of a double cord blood transplant? And as many of you know, there is the first reports coming out that there is a decreased risk of relapse in patients receiving a single cord blood transplant if their degree of HLA matching is at a 4 out of 6 level, as you can see here. This also was observed in our own population of patients that was reported in The Lancet, that with every increase in mismatch, you find a correspondingly lower risk of relapse. What this suggested to us, but maybe one of the mechanisms of why the double cord blood transplants may have a lower risk of relapse, is that in the majority of the cases, one of the units was a 4 out of 6 match. But we're trying to tease out why all the different factors may be playing a role. And in this study population that Mike Veneris has been investigating, looking at all patients that have been transplanted here with ALL and AML, comparing single versus double, let me just go right to the result, which is showing you that recipients of a single had an overall incidence of relapse of 31%, and those with a double an overall incidence of 7%, at least for those that were AML, ALL, and CR1 and 2. So it's at least suggestive that perhaps there is a lower risk of relapse. And interestingly, in a report that's just coming out now from the EBMT, when they've looked at cord blood transplanted adults with lymphoid malignancies, one of the factors that fell out also was the fact that those receiving a double cord blood transplant had a lower risk of relapse in this group of patients receiving non-myeloablative therapies for lymphoid malignancies. So there may be something to this idea that there is a lower risk of relapse in the recipients of a double, and although we don't yet know the mechanisms and we can make some guesses, nonetheless, this is something that needs to be further investigated. Our hypothesis is that maybe each of the units contributes its own GVLA effect and it's also additive, or alternatively, the co-infusion of the two units might result in an in vivo MLR that is in turn resulting in a non-specific alloreactive response. But if that were the case, then you should see a higher risk of graft versus host disease. Now, Margie McMillan has been looking at the risk of graft versus host disease in this group of patients. So if the two units result in an in vivo MLR, then obviously the hypothesis would be that GVHD would be greater in recipients of a double. Well, the answer to that question is yes, there is. And in fact, when you look at the double cord blood recipients, you see the overall incidence of GVHD is 60% in comparison to 33% in our patients receiving a single. And the time to GVHD appears to be about 6 days faster in the recipients of a double. And as you can see, we looked at a number of factors. None of these predict risk of graft versus host disease. It's only the fact of only the presence of receiving a double that predicts the increased risk. When you tease it out by organ system, it appears that the risk is associated with increased risk of skin GVHD. And in fact, when you compare grade 2 versus grade 3 versus grade 4 disease, it's only grade 2 disease that's increased in the recipients of a double and not the more severe forms of graft versus host disease. Well, nonetheless, in terms of graft versus host disease, the risk of infection, immune reconstitution, and the probability of relapse will be investigated comparing singles versus doubles in this randomized trial that's performed as part of the Clinical Trials Network. This trial is ongoing. So if you remember this slide from earlier on, it was our burden of proof to figure out whether or not there would be any changes with umbilical cord blood in terms of graft versus leukemia, transplant-related mortality, and universal access. What we've been able to show is that cord blood does retain graft versus leukemia effect. It is associated with less GVHD. There seems to be a more rapid access to hematopoietic stem cells with cord blood banking, and it appears to eliminate or at least reduce HLA restriction. The next question was whether or not we could reduce regimen-related toxicity and allow transplants in older patients, and could we also then further allow patients to go to higher age groups than was previously entertained. Now, this is referred to in Europe as the Minneapolis regimen. It was developed here where we combine Cytoxan, fludarabine, and single fraction total body irradiation. And again, patients receive a single cord blood unit only if they have a large cell dose. Otherwise, they receive a double cord blood unit if there are two adequately matched units available to the patient. Patients are eligible for this protocol if they're under the age of 70, have a hematologic malignancy, and are high risk for transplant-related mortality, frequently the basis of comorbidities. In 171 patients, you can see that the median age was 51 years. You can see that 46% of the patients went on to this trial solely because of older age, with the remaining patients going on for either comorbidities or having had a prior autologous transplant. In contrast to what you saw previously in the myeloablative preparative therapy, you can see that the median time to neutrophil recovery is 12 days, in contrast to 21 days as you previously saw. And the overall incidence is 92%, which is quite comparable to what you saw with the full prep. Now, one thing I want to point out to you is that chimerism now is transient. There's residual host cells at the earliest time points, but over time they become all donor, as you can see in this figure. A different way, if you recall previously, this is what we saw with a full prep, where you see no host recovery and a transient blip with one unit winning out. You see the same effect with the two cord blood units, with one having a transient blip and then eventually dying off, with one unit winning out. But what's different here is you have this very early wave of host recovery, early after transplantation in the non-myeloablative prep. And it's for this reason that we have that very rapid recovery with the median time to neutrophils of 500 by day 12. When you look at what risk factors predict overall outcome in terms of engraftment, you can see that one factor falls out. Those patients having had recent chemotherapy or prior autologous transplant have a very high rate of overall engraftment, but those who have not had recent chemotherapy, as has been observed with marrow transplants with non-myeloablation, you can see that the risk of graft failure is significantly higher. When you look at the remaining results with non-myeloablative therapy, despite the older age of the population, you see the risk of grade 3 to 4 disease is approximately 20% in large singles versus doubles. Chronic GVHD is also approximately 20 to 25%, and transplant-related mortality is 19%. When you look at the risk of relapse in this population, similar to what was observed in Europe, where they looked at those only with lymphoid malignancies, you can see that there's a trend towards a lower risk of relapse in this mixed population of patients receiving a double as compared to a single umbilical cord blood transplant, translating into an overall event-free survival as shown here, with a trend towards a better event-free survival in recipients of a double as compared to a single. So again, what have we done to prove the benefits of umbilical cord blood transplant? We've retained GVL, we've reduced transplant-related mortality, we've made access universal. The only major category of which we have to yet explore is trying to prove whether or not we've had any effect on immune recovery, and that's work to be done. In addition, we also have other future directions in trying to figure out ways of enhancing engraftment, reducing graft versus host disease, perhaps in those older patients receiving a double, and enhancing graft versus leukemia even further for those patients who come to us with refractory disease. But as one example of some of the work that's being done here, in Dr. Blazer's laboratory, there's been a great interest in looking at regulatory T cells as a way of trying to modulate the immune response in the transplant population. As many of you know, regulatory T cells represent a proportion of the peripheral blood CD4 positive cells. They can suppress an immune reaction, and they can also enhance engraftment and suppress graft versus host disease in the appropriate animal models. As the proof of principle, this is an experiment that was reported in Blood several years ago by Pat Taylor, looking at what the impact of regulatory T cells would be on the overall outcome. And as you can see here in this right panel, those animals receiving T cells alone had a very rapid mortality rate, but those receiving T cells plus regulatory T cells in turn had an overall survival rate comparable to those animals that did not receive T cells, suggesting that preventing graft versus host disease was possible with this immune suppressive population of CD25 positive cells. This then led on to work over the succeeding couple of years trying to figure out ways of expanding human regulatory T cells, both in peripheral blood and cord blood. But as you can see in this population, where we're now doing a trial looking at using CD328 beads, in this population, you can see that we're able to obtain with cord blood approximately 50 to 200-fold expansion at 18 days, depending upon the methodology that's being explored. But suffice it to say, this then led on to a clinical trial, which was initiated in September of 2007. And this was based on the fact that what we could do in this animal model, which is a humanized, basically, animal model, where you can take human T cells, create graft versus host disease. As you can see here, you can see the evidence of lymphocyte infiltration in the ileum, and you can also see the lung and also in the liver. And by then combining these peripheral blood human mononuclear cells with then human regulatory T cells, you had a result that was comparable to the control population where there was no evidence of graft versus host disease. So these pieces of information then led on to that clinical trial, although I don't have results to tell you to date since only a small number of patients have been enrolled thus far. What I can tell you is that this is a dose escalation trial in the myeloablative setting where our goal is to enhance engraftment. And we have a second trial in the non-myeloablative setting where the goal is to reduce graft versus host disease. In this trial, we're already up at the 3rd dose level. Those patients on the 4th dose level, which will be the next group of patients, will receive an infusion on day 1 as well as day 15, which we believe will be what would be in the future needed for preventing graft versus host disease. Remember that the purpose of these 2 trials was to demonstrate safety, and it will be future studies that will then verify the efficacy in terms of preventing GVHD and enhancing engraftment. But also we are entertaining the possibility of using CD25 positive cells for the treatment of autoimmune diseases such as type 1 diabetes. So the question then is that will placental blood replace the need for adult donors? Well, the answer is probably not completely. But what we believe is that it could actually become the predominant hematopoietic stem cell source. And the reason for that is simply due to the fact that we can't find donors for many of our patients already, simply because of the age-linked matching requirement using adult volunteers. So although it may not necessarily be replacing it, it certainly will be a major stem cell source in the armamentarium for transplanters, I think, worldwide. However, even if not proven to be better than 808 marrow, what we need to do is we need to then figure out ways with marrow transplants, how do we improve upon age-linked matching requirements, how do we reduce attrition rates, and how do we more rapidly obtain donors for the patients requiring marrow as well as cord blood. So now I'm going to end with a test. So we have a few minutes before we end, and so if you've been paying attention, you should be able to get these right. Okay, so you have to choose the graft now. Which graft would you entertain? So for those of you who are sleeping during this lecture, you're going to be in trouble. So if you have a patient that is Philadelphia positive chromosome ALL, which of the following graft would you choose? Now, obviously, A through D represents umbilical cord blood, and E represents a 7 out of 8 bone marrow. And just for purpose of this discussion, I'll say that the mismatch is a DRB1. Margie, what would you choose?
I go for D.
Anyone else disagree? Then what would you vote for?
C as the larger single dose that meets our threshold for selection.
The answer is B or D. Well, this is actually the answer as I would do it. However, it doesn't mean that I necessarily have all the right answers. But the reason for choosing B is that although Dan said that he would choose C because it is a higher cell dose, remember that we have data that suggests that perhaps age-linked matching is important as long as it achieves the minimum cell dose of 2.5. However, I can point out to you that many around the world would choose C because it is the largest unit, single unit that's available. But because of the fact that it does have more transplant-related mortality, it is the disadvantage. But if you go back and look at the Lancet data, the outcome between B and C would probably be superimposable. Okay? But there would be higher TRM here as compared to here, and that was the reason why I would have chosen B. Or at this institution, we might have been more likely to go to a double because we were trying to achieve a cell dose of greater than 4 with a 5 out of 6. So at least that provides the rationale of why we would have chosen probably D at this institution. Other centers may have chosen B or C, but that's at least the rationale. Now, we might as well then ask you, Paul, about if you have a patient with globoid cell leukodystrophy. This is a rapidly progressive leukodystrophy that frequently patients are at a very young age when they present, and so there is urgency to moving to transplant rather quickly. Which of the cell doses which of the units would you have chosen if you have these as your choices? Keeping in mind this is a talk on cord blood transplant.
And this is a full prep, right?
And this is any prep you want it to be. But
Well,
presumably full prep.
For the full prep, I consider using A. The reduced intensity prep, I'd probably go D.
Anybody disagree? Is Jacob here? No. I would have chosen B. And although A represents a good choice from the standpoint that it has the best match, and although I have to agree with Paul that the fact is that the data doesn't tell us what the lower limit of cell dose requirement is for a 6 out of 6. In fact, there seems to be no effective cell dose in the 6 out of 6s. But I think that's only because of the fact that we don't have enough patients in that category to be able to figure out what that cell dose threshold for a 6 out of 6 is. But at this institution, remember that we would have only looked at those with a cell dose of 2.5 or greater. So in fact, this might not have shown up in some presentations, depending upon the institution that's involved. However, a 5 out of 6 gives you a good outcome that's comparable to an 8 out of 8 allele matched marrow recipient. And it's for that reason that I would have chosen B as my first choice in this particular setting. Okay, so now how about CML and accelerated phase? Phil.
I would pick, as much as I love cord blood transplantation, I would pick E because it
Even though it's DRB1 mismatch? Should that make a difference then?
What I was going to say was that it gives us the chance to do DLI if we need to in that setting.
So Dan, would it make a difference if it was DRB1 versus B?
Not any clear data from registry analyses that sort that out.
Well, I would have chosen B or E. And the reason I would choose E is for the exact same reasons that Phil has entertained. First off, it doesn't clearly make a difference as to where the mismatch is at this point in time. And as you saw previously with Stephanie Lee's presentation, although a one allele mismatch did confer a 9% reduction in overall probability of survival, this is an opportunity for us to give DLI should that a relapse occur subsequently. But alternatively, you could have made the argument using B if this were a pediatric recipient. You might have expected that that would be a reasonable outcome as well, because as the right cell dose and the overall outcomes with 5 out of 6 with that cell dose is quite comparable to an allele matched bone marrow. But obviously, you don't have the access to DLI should that be needed. So anyway, I want to conclude by saying that clearly there's lots to be learned yet on umbilical cord blood transplant. We've learned a lot over the past 2 decades. And we think that probably the future of cord blood will not be limiting itself to the standard diseases for which we do transplants today. But I think what you're going to see is an increasing use of umbilical cord blood as an effector cell therapy, whether it be NK cells for AML or other malignancies, or there be regulatory T cells for autoimmune diseases, or other cell populations such as mesenchymal stem cells or multipotent adult stem cells for tissue repair. But nonetheless, what we've learned today with umbilical cord blood has led us now to consider this to be the principal stem cell source for pediatric patients and a growing utilization for adult patients. Thank you. Now it's your turn to ask questions. Margaret?
Well, when you're talking about the cell dose in your little example there of the patients, I mean, prior to that, you were talking about different thresholds. I mean, the 2.9, 5 out of 6 certainly is a great graft and would be considered, in other centers. But I thought your other slides were suggesting you would want a higher cell dose of 4 if it's a 5 out of 6. Is that not right?
Correct. So for those patients who receive a cell, what our goal is that what we do is we say you have an adequate single cord blood unit if you have a cell dose that increases with every degree of mismatch. So if you have a 6 out of 6, our cell dose goal is 3. If you have a 5 out of 6, your cell dose goal is 4. And a 4 out of 6 is cell dose goal of 5. The reason why we set those thresholds is somewhat arbitrary. All we know is that that is the right trend and the right direction to go into. We just don't know what the absolute threshold is. But when we don't achieve that threshold, it forces our center to go to a double cord blood transplant to achieve higher cell doses. Because what we do know is that the higher the cell dose, the better it counterbalances the negative impact of HLA mismatch on transplant-related mortality. So that's the goal. Now, if you go back and then move back and say, what happens if you don't have a second unit? Well, certainly having a cell dose of 2.7, 5 out of 6, is a reasonable unit. It's just that at this center, we're trying to push then to go for even higher cell doses. Doesn't mean that it's a bad unit, it just means that we think that there's a better approach, at least based on the data we have so far.
Jonathan, going back to Bill's point, can you take, in a double cord transplant, can you take half of the cells and try to grow them up into donor lymphocytes?
Yes, you could. That's not really been proven as yet, but there's a number of strategies where that's actually being investigated. Shenzhen Zhao is actually looking at using umbilical cord blood T cells and genetically modifying them. But you could also do the same thing with unmodified cells, expand them up, and then seeing whether or not it retains an alloreactive response or a GVL type activity, whether it's modified or not modified to do that. So that's being explored, but I've not yet seen any data that says to me that that's been done successfully, and are they as effective as unprocessed T cells? I don't know that answer.
I'm not sure if, just to follow up on Greg's question, I'm not sure if this is what he was asking, but let's say that you had cord A and cord B, and you took half of cord A and saved those for effector cells, but it was actually cord B that engrafted.
Oh, I thought you meant just the principle of could you say T cells?
Ask about the principle.
Yeah. No, in terms of then, if cord A was the one that did not engraft, and yet there are the cells that you have available, I would predict that they wouldn't work. I would presume at some point there'll be an immune response that would actually, remove those cells. I don't know that answer. But what I would do is I probably in the future might take an aliquot of both from A and B, and then once I knew which unit won, I would then give the appropriate T cell population. That's my.
So John, in one of your slides, you kind of had implied that in the early phases of mixed donor chimerism, where you've got cord 1 and cord 2 kind of engrafting, you implied that perhaps there was hematopoiesis from both units. But do we have any data to support that early, like in the first, let's say, few days of engraftment? Can you find that the neutrophils are derived from both units?
Yes, we have. We did that. The very first patient was the first proof of principle where we actually, the way we proved it was by plucking out individual CFU-GM and verifying the donor origin of each CFU-GM colony. And so although that work has not been done, in great detail subsequently because of the numbers and expense and, the amount of work that would be entailed, at least we can tell you that in a small proportion of patients where we actually plucked out individual colonies, there is a true contribution from each unit of hematopoiesis. Yes.
In trying to figure out which of the, whether it's really random in the double cord transplants, which unit wins out, does anyone look to see whether there's any allo-specific antibody in the patient prior to transplant to either of those two units?
Yeah. Harriet.
Oh, it should be done.
Well, it's Harriet's fault for not having done it. No, but yeah, but,
Samples.
no, but one thing that we did do, remember that we also did look to see whether or not, for a period of time, whether or not there was any anti-HLA antibody present prior to umbilical cord blood transplant. We were looking at cross-matching, and at least early on, we didn't see any benefit to doing that, which is very different than other places. But it's something to be re-entertained and re-evaluated, especially looking at not only before transplant, but also what happens afterwards, and whether or not there is an immune response that occurs to the other unit.
And there's a much easier way to do that using other assays than the cross-match.
So work to be done. Yes, John.
One of the things that you've talked about in the past, John, is the advantage of cord blood in terms of shorter time finding a donor compared to bone marrow. And if that's the case, and if you have data showing that there is a real difference between those that are bone marrow recipients and those that are cord blood recipients, it might be that another variable you need to look at in terms of comparing outcomes in leukemia patients is the time to find the donor, because clearly if you wait long enough, you're going to transplant some cured patients If you do it very early, you've got a different group of patients. So where
That's-
does that stand? Is that a variable you've been able to look at?
Well, it's a variable that we'll be able to address, I think, in the randomized trial. Because in the randomized trial, you have to have both options available to you. And so, obviously, even though the cord blood units may be available, within a week or two, and they may have to wait longer for the, this is a different trial. There is another trial that's ongoing in Europe. We're actually comparing bone marrow versus cord blood. And so we'll be able to answer that question, perhaps, not us personally, but there is a possibility of answering that question.
So far, there's no hard data.
Don't know. I mean, but that's only been an argument that maybe, cord blood, we could be arguing either way. It could be good or bad for a cord blood transplant. But you're right. I mean, obviously, the time to transplant could make a difference in what that impact is overall. We believe that there's, hopefully, it allows you then to drive the time of transplant based on when when the recipient's ready, rather than when the donor's ready. We think that will be an advantage. Did you have another question?
Yeah, can you envision a role where you look at allele-based class 1 typing and take a decision on that as far as blood typing?
Well, I think that in terms of the question about allele level based typing and making decisions based on that, I think that we can't do that right now. What we know is that the allele based typing, right, based on the one figure I showed you from Cobalt, probably would only fall out as being significantly important for those patients that you have several choices out of a 6 out of 6 matched unit. So if you have multiple choices, there you might tease out a group that has allele matched versus any level of mismatch. And that would be important to you. But this represents a very, very small number of your patients. If you remember, only those that had a 9 out of 10 allele matched cord blood had a superior outcome. Everyone else was the same. So in that one figure, it suggests then it would only be those that are really matched at antigen level. Doing it further typing might be a benefit. But I should also point out to you that moving forward, all the patients are being allele level typed. We'll be able to tease that out. We just don't know the answer today. Well, thank you very much. More, stay tuned.